Hello, my name is Dr. Frampton Gwynette, and I'm a child and adolescent psychiatrist at the Medical University of South Carolina. I'm here today to talk about behavioral treatments for autism spectrum disorder, and I'm very excited to be here. I'll start out with my disclosures. I am an employee of the Medical University of South Carolina, and I do have research funding through SC Works in South Carolina. The objective of today's talks, we are going to discuss the evidence base for ABA-based interventions, and there are several variants of that for patients with autism spectrum disorder. We'll also talk about the role of social skills training throughout the lifespan for individuals with autism. Then we'll move on to cognitive behavioral therapy as an evidence-based modality for treating comorbid anxiety, depressive disorders, and OCD in patients with autism. And then we will conclude with a discussion of the key barriers for families who are seeking behavioral interventions and how you can help your families access these services. So an overview of today's talk, we're going to talk about a number of ABA-based interventions. I'm going to put a red line here so you can see that there are several variants, and we're going to run right through those behavioral interventions, and then we will conclude with the non-ABA-based interventions. So to begin, this is a diagram of an autism tree. I'm going to refer to this diagram several times throughout the talk, but my point with this slide is to illustrate the core deficits that we'll find in the DSM-5 for autism. Those would include social communication deficits as well as restricted repetitive interest behaviors and activities. Now those core symptoms are currently being investigated intensively by the medical community. That is a treatment target, and there are over 3,000 articles per year published in the scientific literature trying to target those core autism symptoms. However, to date, there are no evidence-based biological treatments. Only behavioral therapy impacts core autism symptoms. So despite the medical world's response to the worldwide epidemic of autism, this is the lay of the land as we stand today. Now, autism is a very complex disorder. If it's not the most complex disorder in the world, it's certainly one of them. And this slide illustrates the complexity of autism and the various challenges and facets that families face as they're walking through this world. On the left side, you'll see a list of some of the therapies we're going to discuss today, and behavioral therapy, first and foremost, is the keystone or the foundation of any good treatment plan. However, there are multiple other dimensions to this disorder. Many patients take medications, over half in fact, some take multiple medications, and families are faced with decisions about what they should begin. Should they treat for aggression or treat for ADHD and so forth? There are many school challenges, as we've heard a lot about that from Dr. Kathleen Koth in her lecture on the multidisciplinary team and the IEP process. Certainly the IEP, accommodations, is there bullying going on at school? Should this child be homeschooled? Is there a behavior plan in place? And so forth. There are lots of medical professionals who are also in the treatment team, including pediatricians, neurologists, maybe a GI specialist, as well as, of course, speech and language pathologists and occupational therapists, just to name a few. Don't forget about neurology, since many patients with autism also have seizure disorders and other neurological conditions. Many times there are other agencies like insurance companies, also schools of course, but also maybe county or state disability boards that also factor into the equation. And then finally, we heard a great lecture on transitioning planning from Dr. Natasha Maris, and that's really the elephant in the room. So even from the very beginning, parents and families are already thinking ahead to questions like, will my child graduate from high school? Will they attend college? Will they live on their own, or will they live with the family for the rest of their life? Finding a meaningful career, and of course, estate planning and family planning. So with all of that going on, it's easy for us to take our eye off the ball, but it's important to remember that behavioral therapy is the cornerstone of treatment for patients with autism. So next I'm going to go back to the autism tree, this time to illustrate, yes, we have our core symptoms here at the tree trunk, but we also have a lot of comorbid psychiatric conditions. And Dr. Roma Vasa gave a wonderful talk in this lecture series about co-occurring psychiatric disorders. Among those that come into our office, you'll very frequently hear about ADHD as a target symptom, or anxiety, Aggression is another big one. Some patients come in with sleep problems and so forth. But I want to point out that we have some potential to treat symptoms up in the branches of this tree with medications. The best example of that would be risperidone and aripiprazole, which are FDA indicated for the treatment of aggression in autism. However, we must note that aggression is not part of the core autism symptoms. So I'll use this arrow again to remind us that behavioral therapy are the only modalities evidence-based for core symptoms. In fact, here's that red line again showing us that really when it comes to the core symptoms, medications and all biological treatments are not evidence-based. They cannot go beneath this red line at this point. Interestingly, behavioral therapy can go above the red line because we're going to hear later in this lecture about how behavioral therapy can be useful for treating anxiety, depression, as well as OCD in individuals with autism. Okay, so we're going to move into the heart of the talk now with behavioral therapies, and really no discussion of autism behavioral therapies can begin without mentioning applied behavioral analysis. So we also know that as ABA. And in a nutshell, ABA is a teaching method that is designed to decrease inappropriate behaviors and to increase desirable behaviors. Now I'll put the evidence up front that there is a medium to large effect size for ABA when used over the long term and in a comprehensive way. And it hits some of the targets that are very, very valuable in terms of long-term functioning. Dr. Maris has mentioned the importance of language development in long-term outcomes. Of course, intellectual functioning factors in significantly as well as daily living skills and social functioning. So all these, when you think about transition from childhood to adulthood especially, the struggle and the battle begins very early on. So ABA is able to move the needle, especially when it starts early and is delivered in a comprehensive fashion. So a little bit more into the nuts and bolts of what ABA is. The analysis piece is interesting because that describes the process of understanding the function of a certain behavior and how it's affected by the environment. For instance, there may be a child who has some aggression, and we want to know what is the function of that aggression, what's triggering it in the environment, and how can we use techniques and principles to bring a meaningful and positive change in that behavior so the child is no longer aggressive. ABA includes a lot of positive reinforcement, a lot of repetition, and very specific treatment goals. So along the path of using ABA, I have this beam intensity dial here to illustrate that we're going to look at something called a discrete triad, which is a very focused lesson on how to build a skill. And we want to, through repetition and positive reinforcement, build up those skills over time and start stacking those skills. So going back now to the function of a behavior, ABA focuses on identifying the function of behavior, and most commonly, functions of behaviors are listed below. And I'll give an example. For instance, if a child is aggressive, the function of that might be to escape something, like to escape maybe homework or a non-preferred activity. It may be to access a preferred activity, like if someone's carrying a cookie in front of me and I want to get that, I might be aggressive to try to get that cookie. It could also simply be to have attention. If someone comes in and is taking attention from me and I start to get aggressive, I will very likely get more attention. And finally, it can be just internal stimulation. Like, for instance, if that aggression is turned inward, many patients will have self-injurious behaviors such as scratching or slapping themselves or hitting their head just as a way of self-stimulating. So those are 4 common functions of certain behaviors. Now, I wanted to break ABA down into its antecedent, behavior, and consequence compartments. So we've got ABA, and then we've got ABC. So in the case of the aggression that we just mentioned, we may have an antecedent of the child's being asked to do classwork, and then their behavior could be aggression, and the function of that behavior could be to escape from the classwork. But we want to be careful how we address the aggression, because if the child gets aggressive and we give them an iPad, for instance, to soothe them and calm them down, well, then we're reinforcing that aggression in a way we probably don't want to. Ideally, we could present the child with classwork, and then if a meaningful change is made, the child could complete the classwork and then get time on the iPad as a reward for completing that task. So that's the ABC, antecedent, behavior, and consequence. Now, each child's skills need to be assessed, and in ABA, all the goals are individualized, and they can be broken down into different areas. So the skill areas might include social skills, cognitive skills, motor skills, appropriate play skills, academic skills such as reading, writing, as well as self-help or language skills. So I have a picture of a grilled cheese sandwich here to illustrate how basic this can sometimes be. So if there was a child who had a lack of verbal skills and had cognitive delays, we might present them with 3 pictures of different foods and say, I want you to point to the grilled cheese sandwich. And so the child would be listening to that verbal request and then acting out, picking out the right picture and then going ahead and pointing to it. So there's a joint attention exercise there as well. Now, without further ado, I want to introduce a video depicting ABA therapy, and we're going to see discrete trials taking place. His therapist, the therapist here will talk, you'll see the therapist running through a very specific skill set, and once the skill is attained, the child will receive a reward. In this case, it's a goldfish cracker. I've seen this video a number of times, and one thing that was making me smile recently was watching it in the beginning that the therapist is actually talking with the reporter, and the child is going ahead and eating the goldfish crackers at will, which is not ABA based. He's just going to town on those snacks. But later in the video, you'll see that he only gets the goldfish cracker when he completes a skill. So let's take a look.
Children once trapped in their own world are swirling into the mainstream thanks to a breakthrough therapy happening right here in the Bay Area.
All of our kids make progress. It does depend on how early we get the child. So, the younger the child comes in for therapy, the better it's going to be. If there's a lot of follow-through at home, obviously, then we would have better results. But all of our kids are making progress. All of our kids are communicating. Some kids are using vocalization. Some kids are using sign language. But all of our kids are moving forward.
Kelly Prince is the president of Behavioral Consulting and a skilled therapist. At her clinic, children formerly diagnosed with autism spectrum go into 10, 20, even 30 hours a week of intense treatment. Because children with autism often can't communicate, therapists help them develop a love of language.
Can you say banana?
Banana.
Nice. Try saying nana.
Banana.
Nana.
Banana.
Nana.
Nana.
Nice job, buddy.
Learning to communicate helps autistic children better control behavioral issues. It takes time,
Can you touch the frog?
repetition, and a lot of patience.
See, I did it.
I did.
That's a great job.
Charlie now has the cards stacked in his favor to one day be mainstream. This past April, Governor Charlie Crist signed a new bill called the Window of Opportunity Act. It is designed to have the private insurance sector help offset the cost of early intervention treatments, and that could save millions of dollars every year.
So what we saw in that video was a discrete trial taking place with a very specific skill set. Initially, the therapist was asking the child to say banana, and he wasn't able to say the full word, so she asked him just to say nana. And once he did that with prompting and eye contact, he was able to get his reward. Also, the therapist mentioned a couple of key points that I want you to remember. One is that early start is advantageous, and also parental involvement helps boost the efficacy of ABA. Also, you'll hear that at the end, the reporter was talking about insurance mandates put forth by the governor of that particular state. And that's important because, first of all, it speaks to how expensive these resources can be, and also how effective they are. So you've got an effective intervention that's also very expensive, and therefore the need, in this case, for the governor to step in and mandate coverage for this behavioral intervention. So that's ABA therapy. Now, a little bit of a reminder about the discrete trial. Again, it's the process of breaking skills into little pieces and then building that skill through lots of repetition and positive reinforcement. Now I want to speak to the different ABA subtypes and break them out according to ages. So in very young children, there are several interventions. We're going to talk about 2 today. One is early intensive behavioral intervention, and the other is the Early Start Denver model. And this would be for kids as young as 12 months to 18 months, so very young children. And these are variants of ABA. And then straight ABA can also be used in school-age youth to deal with problem behaviors. And ABA therapy can also be used in adolescents and even adults to reach life skill goals, social goals, and also educational goals. So let's come back to our tree again, and I wanted just to point out that ABA therapy has multiple offshoots that were mentioned in the previous slide, but we're going to walk through each of these now and talk about how they're effective. So the first is early intensive behavioral intervention. And this was among the first comprehensive treatment programs for patients with autism. It is applied behavioral analysis based. ABA was brought into the world of autism by Dr. Lovas at UCLA in 1981. And the principles of ABA are used in early intensive behavioral intervention. This is intensive, meaning that it lasts 2 years or more. It involves 25 to 40 hours per week of intervention. And also it's a one-to-one ratio, so you have one child and one therapist. And that's where we get that intensity from. Also, a parent component boosts the efficacy and boosts the generalization of skills. And generalization means not just seeing the skill in the clinic, but also seeing it in the child's life elsewhere, such as in the school, or at home, or at church, or in other activities. Now, things that are intensive are also expensive. So I pointed out the dollar sign there. And that's going to factor in later at the end of this discussion when we talk about barriers to accessing care. So in terms of the evidence for early intensive behavioral intervention, it's very encouraging. We have medium to large effects for intellectual functioning, language skills, and adaptive behaviors. And the data clearly shows that when parents are involved, the intervention is even more effective. Also, gains from early intensive behavioral intervention are maintained even 2 years after the intervention has been completed, and that core autism symptoms are improved, as well as adaptive behavior. In addition, we know that early intensive behavioral intervention helps with mainstreaming in school, and that means the child has more of a chance to graduate. That means that they're spending less time in a self-contained classroom if they've received this intervention. And we know, looking further down the road, that more mainstream classes leads generally to more success in adulthood. Prognostic factors, again, you'll hear this over and over today, that starting early, such as 12 to 24 months, is a good prognostic factor, as well as children who have a higher IQ at the time they start. That said, ABA therapy is effective for older children and lower functioning children. Okay, so now we're going to move into the Early Start Denver model. And this is another variant of ABA. It's very naturalistic. And what I want you to remember from Early Start Denver model is it's a relationship-based intervention. So it integrates ABA techniques into a model that emphasizes eye contact and a social interaction and a reciprocity. And an affective engagement. We're going to see a video momentarily, and you'll see the therapist really being very animated to draw the patient in with eye contact and with an interaction. The leaders of Early Start Denver model are Geraldine Dawson and Sally Rogers, and this clip that we're about to see now has Dr. Rogers featured, and we're going to take a look right now.
The Early Start Denver model is a method of intervention developed for very young children. And it draws from a number of different sources, both theories and science, something about these really, really little ones. I think they're still in a developmental period where their peers are learning to talk. They're not out of sync yet with other 18 to 24-month-olds. Everybody in that age is learning to talk.
And we'll go, open boats.
At 18 months old, Matthew was noticeably behind his twin sister and his peers in verbal and social development.
Cupcakes?
But researchers believe they could help him catch up fairly quickly.
Caterpillar. When he first came to us, he had no language. He made very little eye contact. He had very few play skills. This would be a great way to work on jumping with 2 feet.
He's very good at jumping.
Do you want more juice?
Yeah.
Yes.
Amy Board is a speech pathologist and the team lead for Matthew's intervention, which included a handful of therapists as well as his parents, who also received training so they can continue the treatment at home. It's an intensive 20 hours of therapy each week.
Where was Matthew's focus during the ball routine, do you think? So during the book routine, you saw me elicit eye contact. You saw me do vocal imitation with him. You saw me elicit sound effects with him with the slurping of the soup. Worms are yucky. And the idea is that we get to teaching about every 10 seconds. So about every 10 seconds, you're going to see some kind of a learning opportunity. And that's our fidelity goal with the ESDM model.
And the results? After 5 months of therapy, it would be hard for someone who doesn't know Matthew to see a difference between him and any other child his age.
So a couple points from that video. One, these are very young children, 12 months to 24 months, and they're being treated at a time when they would otherwise be talking if they didn't have autism. So they haven't yet deviated very far from the normal developmental trajectory. That's important. Also, as we saw, the therapist was making sound effects and getting the patient's attention, playing a game together. And you'll see they were also at home in a natural setting, and the parents were right there sitting on the couch. So the parents are deeply integrated into Early Start Denver model. This is kind of a recap of the features of that video. But this is an affect-based relationship going on between the therapist and the child. Again, when they say early start, they're not kidding. 12 months of age, very young. It is applicable in a wide range of settings. So we're talking school, home, and other settings. And also, the curriculum is very specific according to the individual needs and targets of that patient. The data is outstanding. It indicates a positive response in child development across a number of critical domains, including intellectual ability, expressive and receptive language, adaptive behaviors, and even it's been shown that children who complete Early Start Denver model have a less severe autism diagnosis at the end of intervention, although that was with unblinded raters. So that's still very encouraging. Moving on to pivotal response training. This is the final ABA variant that we're going to discuss today. But this is a unique type of ABA therapy, and I want you to think about the word motivation when we discuss pivotal response training, because it's really about engaging the child on their terms and keeping them motivated and invested so that behavioral reinforcement loop is constantly active and constantly being reinforced. So again, the evidence base here is large. Pivotal response training has been used across a wide range of settings with multiple designs in experiments. And also, it involves something called pivotal target skills. And I'm going to talk about those a little bit now. So the pivotal piece comes from the idea that, discrete trials start in a very linear fashion, just building lots and lots of skills on top of each other. Pivotal skills is the concept of trying to find a few very important skills that can be targeted so that they can create a chain reaction, an explosion of skills, and all the while keeping the child motivated and invested. So you'll see the pivotal skills as initiation, self-regulation, and responding to multiple cues. And we're going to see a video momentarily. And I was trying to conceptualize the nature of a pivotal skill. And one of the graphics I came up with involves dominoes, because dominoes can be certainly set up in a linear fashion. You can knock one down and they can go in a linear fashion straight down. But the developers of the pivotal response training, I believe, looked at the key dominoes in this picture and said, what are the key pivotal skills that we can target that can then set up a chain reaction so we can knock down all these dominoes if we focus here first? So that is hopefully a helpful illustration about the concepts behind pivotal response training. So in the following video, you're going to see an example of a one-on-one interaction using pivotal response training. And I think the interesting piece here is that the child is given choices. Choices about what activity to engage in, choice even within that activity about which puppet they want to play with. And you'll see the therapist elicit eye contact and really stay engaged with the patient and follow the patient's lead about the activity and working their lessons in within the fabric of the child's interests.
Hi, Mary. Mary, hi. Here. We're going to play with some toys today, okay? Look at all of these toys. What toy would you like to play with? Toy. Do you want to play with the puppets? Okay, nice job letting me know. What puppet would you like to play with? Okay, you want to play with the
Frog.
with the frog? Good job. What color is it?
Green.
Green. It is green. Can you say green frog?
Green. Frog.
Nice job. Here you go. Okay, I'm going to play with the yellow duck. This is fun. Hey, look. What is the duck doing?
Eat.
You're right, the duck is eating. Hey, what is your frog doing?
Goldfish.
Would you like a goldfish? Okay, nice job telling me. Okay, say goldfish, please.
Goldfish.
Please. Good job.
So it's interesting, in this video, they also use goldfish as a reward, but you'll see that the therapist, first of all, offered the activity to the patient, and then once the patient chose they wanted the green frog, she held the green frog back, waited for the child to say the words green frog, and then the therapist handed the toy over to the child. And then the child started engaging in play, and eventually they got to the concept that the green frog was hungry and was eating goldfish, and at that point the therapist received the cue from the patient. The therapist reached in her bag and got a goldfish and gave it to the patient. So that lesson, that reinforcement is there, but it's very patient-led and patient-driven. And this is a summary of the differences between a discrete child training and pivotal response therapy. And I've highlighted two here. One, in pivotal response therapy, you'll see the child take the lead, and also the concept of using highly motivated natural reinforcement and activities to keep the patient engaged. Another difference between discrete trial training and pivotal response training is the concept that I call partial credit. But it's just to say that pivotal response training reinforces not only the correct behavioral response, but also a meaningful attempt or a valid attempt to complete that response. So instead of waiting and waiting and waiting for the child to make a completely correct response, even a partially correct attempt or a valid attempt will be rewarded, so the child is constantly in that reinforcement feedback loop. This increases, again, the motivation and the engagement, which is really the key concept of pivotal response training. Okay, now we're going to move away from ABA-based behavioral therapies and move into TEACCH, which is out of the University of North Carolina. It stands for Treatment and Education of Autistic and Related Communication Handicapped Children. And if you think about one concept with TEACCH, I want you to remember structure, okay? Structured environment, structured schedules, structured teaching. And this therapy has been around for a long time, since the 70s, and it's been applied to a wide range of patients with autism from toddlers into adulthood. So just a rundown of the principles of structured teaching. It involves the understanding of the culture of autism, and I'm going to give you a detailed slide next to show you exactly what that culture of autism entails. It also, of course, involves developing an individualized plan for the patient, but also their family. It's heavy into structuring the physical environment, and that makes everything predictable and understandable for the patient. So now let's go to the culture of autism. TEACCH, I think, plays to the strengths of an individual with autism, because they recognize the strengths, they recognize the relative weaknesses, and they say, let's play to our strengths. So some of those strengths include processing visual information, also include systematizing, but also may be countered by difficulties with organizing ideas or integrating concepts, as well as sustaining attention, or also maintaining concepts of time and time management. There are also obvious communication problems in individuals with autism. Children with autism are attached to routines, but that can be a strength if the environment is structured as such to be predictable and structured. So going to the data on TEACCH, there are moderate to large gains in social behavior and maladaptive behavior. The data is not as strong, but still significantly positive in areas of motor, verbal, cognitive skills, and perceptual skills. Effects on adaptive behaviors like communication, activities of daily living, and motor functioning were negligible on meta-analysis. So here comes another video. We're going to learn about the TEACCH method. And again, we're looking at structure, we're looking at reward, and we're looking at the actual physical setup of the room and the setup of the tasks and how they play to the strengths of this young lady with autism.
My name is Alice, and I want to tell you, this is where I learn. It has structure, with clear areas where my learning takes place. They find a place for me to work, a workstation. My teachers show me my visual timetable. We work together so I can focus on what we're doing. And I can get my reward later. This helps me become independent so I can do my timetable on my own. I like it when the tasks are laid left to right and I know that there is a finish. I start with what my teacher calls a posting exercise. After this, we'll make it harder by doing a two-part posting exercise. We also work on matching activities, fine motor skills, and lots more. Once the work is finished, we put it in the finish box. I learnt the idea of finish by using my finish box. When I am done, I get my reward.
So you see a very different approach from ABA therapy, but also quite effective. Okay, now we're on to social skills training, and this is an area that's very near and dear to my heart as I direct a program for individuals with autism where we provide social skills training for patients with autism and also parent support and education, which is a vital piece. In my practice, we come across a lot of youth with autism who may be very bright, but for some reason are having difficulty making social connections, and that has a cascade effect throughout their life. For example, they may want to have friends, but really don't have the skills to make and keep friends. They may want to be involved in activities, which is a major source of our friendships. If we think about in our lives how activities dictate our friendships, if you think we may have friends from high school, friends from college, friends from church, friends from the baseball team, friends from work, and so forth. So when individuals with autism struggle to make friends and make connections and struggle to get involved in activities where they can have friends, it really amplifies their social isolation. Even though they have great cognitive ability and want to have friends, they just are not able to quite make it all connect up. So that's where social skills training comes in. It's really about teaching patients how to make and keep friends. We start on a very basic level, making eye contact, having a back and forth conversation, exchanging information, finding common interests, finding common activities. I'll tell our parents and our kids, birds of a feather flock together. So if you find a peer who's interested in Star Wars like you are, that's a great way to kick off a conversation, and we can build activities around Star Wars. So we're going to talk in more detail about social skills training, but many children do engage in social skills training throughout their lifetime, so it's very common. But what's not common is to find an evidence-based curriculum, so we're going to talk about one in particular that has very strong data. But social skills training as a whole has beneficial effects for social skills, but also on family chaos. It increases the parent's self-efficacy, but it also teaches us that we have a lot to learn about how our patients with autism get socially isolated and how we can address that. So social skills training can be applied in a number of settings, including clinics. They can be applied in school. They can be applied to a wide range of children, including preschoolers, school age, preteen, teenagers, young adults, all the way into adulthood. So really it's never too soon or too late to start social skills training. Now, to single out one particular program, the PEERS program at UCLA, which has been developed by Dr. Elizabeth Logeson, is outstanding due to the fact that there's so much evidence behind it. This program began at UCLA, but has and started in the population of adolescents, but has been now adapted for young adults as well as school-age children. Interestingly, this intervention shows improvement in social skills up to 5 years after the intervention has concluded. It also shows improvement in social anxiety, as well as changes on EEG for completers of the program. It's been replicated in multiple sites, multiple countries in fact, and has been shown to be effective. And the age groups that do respond include adolescents, young adults, and even school-age patients. Now, TEACCH program, just to flash back a moment, also has been shown to be effective, and that involves 20 sessions over for 2 hours at a time over a period of 6 months. So those are two of the most commonly used social skills training programs. So next, we're going to take a live look at an autism social skills training session, and this is a video of the PEERS program.
This is no ordinary teenage get-together. It's actually a serious lesson on social skills for autistic kids, and it's part of a unique program at UCLA called PEERS.
How do you have a successful get-together with someone? How do you go up to a group of teens and join their conversation? And unfortunately, our kids with autism, they're a little bit more challenged in that area, and they don't naturally understand these social cues.
Actor Gary Cole and his wife Teddy worried about their daughter Mary transitioning into middle school. So they brought her to PEERS, where autistic teens get concrete rules on social etiquette, specific steps they can take in certain social situations, and the opportunity to practice.
Are they trying to get a reaction out of you when they tease you? I'm going to give you some new strategies tonight to trouble that aren't going to make them want to retaliate against you. Okay? Now here's the thing. This is how you act like what they said didn't bother you. You give them a little comeback that tells them what they said was kind of lame. You say something like, whatever. So what? Big deal. Who cares? Okay, so let's try this again. Man, Mira, those shoes are ugly.
Whatever.
I'm serious, those are some really ugly shoes.
Yeah, and
Those are some ugly shoes.
who cares?
Okay, very good. Round of applause for Mary. Well done.
While the class is going on, the parents are being coached in the next room, learning to assist their teens in making and keeping friends.
So in that video, we saw a lot of great stuff. We observed Dr. Elizabeth Logeson teaching ecologically valid skills to teenagers. In that particular lesson, they were discussing how to fend off bullies, how to mitigate bullying in the school environment, for instance. And you saw her teach a young lady how to make a clever little comeback to kind of diffuse the bullying and send a message to the bully like, you should probably move on to the next person, because I have skills to defend myself against bullying. And of course, one of the most protective factors against bullying is having friends, having a peer group that is around you. So this was an example of the skills being taught in social skills training. And then we also saw footage of the parent group. Now, PEERS is a parent-assisted model, and therefore the parents are learning how to teach their kids these skills and also help their children complete homework within the social skills training. And the parents do rely on support from other parents. And interestingly, the parents are asked to help their children step out of their comfort zone. For instance, children in PEERS need to complete homework after every session, where they start out calling other group members and having a conversation, finding common ground in that conversation, and exchanging information, while the parents kind of listening from the other room to see how the conversation goes. And then later, the child will kind of graduate up to hosting a get-together in their home, and they'll have to organize the activities. They'll have to make sure that food is around, have to make sure that they're a good sport when they have a guest in the house, and that the guest is able to determine what we do next at that activity, all while the parent is helping to facilitate that. So this is a parent-assisted model. It's been very effective, and again reinforces the point that deep parent integration is almost always a great thing in the world of autism. Okay, next we're going to move into some ground that may be familiar to you as a child and adolescent psychiatrist, because we're going to talk about cognitive behavioral therapy. We're going to talk about how it's applied to patients with autism. So CBT has been used in autism, and recently there's been a really nice surge in the evidence base in this field. CBT is used to treat anxiety in autism, and the curriculum used has been modified in order to make it custom made for individuals with autism. And it's been applied to patients who are cognitively and verbally able. Now you might be asking, how is it exactly modified? Well, remember that patients with autism typically are very visual, and so CBT that's been modified for autism involves a lot of visual supports. And also there's not a lot of abstraction, you know, there's not questions like, hey, what would you do in this scenario? It's more like concrete, where you provide the patient with a list and say, how about we look at this list and use these skills when you're anxious. As well, the adaptations include modifications to help boost social skills, because we know that's a well-known deficit. And it also identifies strategies to help the skills generalize from the clinic into real-world settings, because really patients with autism have impairment in a wide range of settings. And also in CBT for patients with autism, you can use their preferred interests and go with it. Like, for instance, if they're really into Superman, you could build that into the CBT lesson and say, okay, how would Superman fend off anxiety? What skills would Superman use in this scenario? The data for CBT and anxiety for patients with autism is excellent. There are 12 studies which show significant reductions in anxiety with a medium size effect, as well as remission rates which range from 38 to 71%. There's also been 2 studies for CBT and anxiety in adults, and one was positive and one was negative. But again, this is really a surge in evidence coming down the pipeline, and I would anticipate we're going to see a lot more in the near future. Moving on to CBT for OCD and depressive disorders, there has been 1 study each for OCD in adults and in youth, both of which showed a reduction in OCD symptoms. And for depressive disorders, there have been 2 studies each in youth and adults, but the evidence has been mixed so far. But I would be very optimistic that CBT will eventually show pretty good data, especially if modifications continue to be made that apply specifically to individuals with autism. Okay, now we're into the conclusion of the talk, and if you haven't guessed by now, I'm a big fan of early intervention versus late, and you'll see that in a theme throughout all of our talks in this series. The good news is that if we intervene early, we can make big changes in the lives of our patients, and we can get robust responses in behavioral therapies. That's the good news. The bad news is that we know that there are significant delays. In fact, the literature shows us that on average, from the time the parents are first concerned about autism to the time they get a diagnosis, the average length of time is 3 years, 4.5 office visits. So that's not good news. So we want to always encourage our families, whether it's through a very frank conversation or whether it's through writing a letter to a school or writing a letter to a case manager, anything we can do to help speed up the diagnostic process is going to pay off big dividends later. This is a diagram just kind of illustrating what I call the long and winding road, but also what Zwigenbaum et al. Has called the diagnostic odyssey, because there's a lot of steps in the process of getting diagnosed with autism, and sometimes it's a very lengthy process. Maybe it's because the parents aren't really taking the symptoms seriously, or maybe it's because there's a lack of resources in the community to get diagnosed. But we know that behavioral interventions for autism can't begin until the child has been diagnosed with autism. So this is a very important piece. And so anything that you can do in your practice to speed up this process will have a big impact. Of course, our goal is to have a favorable clinical outcome, so we're keeping our eye on the ball at all times. Now, links to early diagnosis. I think it's important to identify which factors we can look for in our clinics that might be a difference maker. So the ones highlighted here separate out children who were identified and diagnosed with autism at less than 3 years versus more than 3 years. And these symptoms will sound familiar. Lost skills or regressed, doesn't sleep as much as other children, delayed response to their own name, doesn't point or show joint attention, doesn't imitate, has delayed babbling or speaking, and then has poor eye contact. So of course these are targets for a lot of behavioral therapies that we've mentioned before, but there are also ways that we can identify kids who are at risk, and we can really emphasize to the entire treatment team and to the family that we want to get a diagnosis as quickly as possible. Okay, so in terms of access to behavioral treatments, I implore you to please pick up the phone if needed, fax a referral, write a letter, anything you can to shorten the time to diagnosis so we can increase the window of therapeutic opportunity. Sometimes, I see myself, and I know other colleagues do as well, as a coach or a quarterback or the director of a film, trying to make things happen. Even though I might not be writing a prescription here, I can still make a huge impact on this child's life. And remember, there are no evidence-based biological interventions that treat core symptoms, only behavioral therapies. So in summary, we've discussed early intervention in autism, and we've seen that it leads to improved outcomes. We know that behavioral therapies comprise the core evidence base for treatment of autism, really the cornerstone, because they treat core symptoms. Also, psychiatrists, such as yourself, can optimize clinical outcomes by helping families access behavioral therapies. And then finally, ABA-based behavioral interventions and cognitively based interventions have robust evidence for their effectiveness. Thank you for your attention, and I'll conclude there.
It was a wonderful talk, Dr. Gwynette. Thank you very, very much.
Absolutely.
I'm going to ask a couple of questions just to clarify a few points.
Sure.
Okay. Is ASD really increasing, or are we just becoming more efficient in finding it?
That's probably one of the most common questions I hear, and yeah, it's a complex answer, but I believe that autism is increasing in prevalence. I think the data pretty clearly shows that. That said, we are certainly finding it, I think, more efficiently with our diagnostic processes. So, I think looking forward, the combination between genetics, knowing that older parents are higher risk, among other medical risk factors, as well as environmental risk factors that may be, investigated more. I think we're going to continue to see, an increase in the prevalence.
Okay, wonderful. Why is it so difficult to get ABA therapy approved and paid for?
I think the short answer to that is because it's so expensive. And the reason it's so expensive is because it's so many hours with a therapist. Before I really thought it was insurance driving it, that insurance didn't want to pay. And now the pendulum has swung a little bit, and the reimbursement for ABA services is so low in some states that you can't find an actual provider who will provide the service because they're not being paid enough. So, it's really, I think, a failure on the part of our system, either not providing ABA therapy when appropriate or not providing in a timely fashion because of wait lists or a lack of availability of providers.
Absolutely. The low reimbursement rates is really hindering being able to get those. Wonderful. Do you need an ADOS to be able to make a diagnosis of autism spectrum disorder?
Actually, Dr. Koth, you do not. So the diagnosis is made using DSM-5 criteria and clinical judgment. There are certain tools, such as the ADOS, that can be used in making that decision, but ultimately it's up to the physician using the DSM-5 criteria to make the diagnosis.
Wonderful. One more question. You made a great emphasis on early intervention. Clearly is the gold standard and what we'd like for everyone. But is there use for ABA throughout the lifespan?
Absolutely. I think a lot of times our focus is on children, and young children especially, because we do know we get a high rate of return. However, problem behaviors exist throughout the lifespan, and ABA can be used and can be used effectively to help diminish things like problem behaviors or enhance skills such as educational skills or work skills or even social skills.
Wonderful. Thank you so much for all of that wonderful information.
Thank you.
Thank you.